So I'm delighted to introduce our next speaker, Erin Fahey-Harrison. She's an outpatient physician assistant, senior instructor with our team here at CU Anschutz. Erin received her bachelor's degree from Vanderbilt University and completed her master's degree as a PA at Emory University. Erin first came to Colorado after being accepted to the hospital medicine fellowship, which some of us have also attended. It's a great fellowship. She became interested in the blood cancer specialty during this time and has been an amazing member of our APP team, both inpatient and outpatient, for over 5 years. Erin serves on our lead council and is co-chair of the Lymphoma Committee within the Blood Disorders Center. She's been instrumental in developing our lymphoma program, including guidelines, education, and processes surrounding the care of lymphoma patients. I'm honored to introduce my friend and colleague, Erin.
Hi, everyone. Thanks, Sarah, for the introduction. Okay. Oh, that's not the right button. Maybe just doing on the computer. Changing the slides. Oh, maybe just go the right way. Got it. Okay. Awesome. So I'll be talking to you guys about B-cell lymphomas. I was talking to some people before this talk about Kelly called it exciting. It is an exciting field to be in as far as all the options, but it's also hard to talk about because there's lots of new things. Like I was talking to a physician just yesterday about some questions that I was still unable to answer myself when I was doing some lit review. And he was like, actually, this paper came out 3 days ago. And I was like, I'm sorry, I don't know that I can update the presentation with things that are coming out 3 days ago. So it is a very exciting field, but also can be hard at times to know what to do with all of the advanced testing and what order to put the different chemotherapies and treatments in. And so the first 2/3 of my talk, I'm trying to actually help people understand what goes into deciding what therapy we're doing now that we have so many options. So these are my objectives. I probably won't read through them. I kind of just gave you that. At the very end, we'll go through relapse and refractory setting. But I will say I put most of my time in literature review into the first line setting because there's been actually lots of changes recently in that. So I have no financial disclosures. So I'm talking about B-cell lymphoma. It's a cancer of the immune system. We're talking over here on this side of the page. I'm not going to even say left and right because there's a good chance I'll be wrong. But the lymphoid progenitor side of the page. Here we go. Oh, I even knew that I would want to point that out. Look at me. Got it. Classification of lymphomas. You've probably all heard of Hodgkin lymphoma, and then we have non-Hodgkin lymphoma. Hodgkin lymphoma makes up about 10% of our lymphomas. Non-Hodgkin lymphomas is everything else. So much more common because it's a much more broad spectrum of diseases. We then can separate non-Hodgkin lymphoma into B-cell lymphomas and then T-NK cell lymphomas. And at our facility, we call those the Brad Haverkos lymphomas. No one else really likes those. So just because they're hard, not because we dislike the patients. But the B-cell lymphomas then and T-NK cell lymphomas can then be separated into indolent and aggressive lymphomas. And this B-cell side of things is highlighted in red because those are the diseases I'll be mostly focusing on. So again, in non-Hodgkin lymphoma, we'll separate it into aggressive and indolent. And again, in red are the ones I'll be focusing on today, which is DLBCL, diffuse large B-cell lymphoma, which is the most common type of non-Hodgkin lymphoma in the United States. And then this like sort of new spectrum of diseases called high-grade B-cell lymphomas that are kind of now a separate category in the NCCN or WHO guidelines. So I like to point out that, again, why lymphoma is so hard to talk about sometimes. It is one of the most variable types of human cancers. It can range from, I think, one of the most indolent that possibly humans can have to actually the most aggressive when you get to like a Burkitt lymphoma. And the reason is because this is a schema of the differentiation pathway from a stem cell to a young B cell there in the bone marrow Then you get pushed out of the bone marrow and in the blood, and a few more like somatic mutations happen, which bring it through a differentiation. And then it enters the lymph nodes. And throughout the lymph node, even more somatic mutations are happening to further its differentiation. And at any point in this process, you can get the cancer cell. So the progenitor cell can be from any point in this process. So it's just a hugely variable disease, depending on which of these cells becomes the malignant cell. So you can even kind of see here where it's even located within the lymph node can help you decide Burkitt lymphoma versus follicular or DLBCL. The mantle cell lymphomas are from a different part of the lymph node called the mantle cell. All of these areas of the lymph node are going to contain B cells that have a different cytogenetic profile, which is kind of how we diagnose them as well. I'll point out here because I get to it a little bit later, but you'll see DLBCL is listed with a GCB subtype, which is a germinal center B cell. So they come from the germinal center. An ABC subtype is sort of an activated B cell. So after it's left the germinal center. So it's all really based on where we are in the B cell maturation process when the cancer arises. I also have a patient case. So this patient case is sort of just meant to bring us through all of the different decisions that are made throughout this process and when they're made and how they're made. So we have a 64-year-old female. She presents to her PCP with dull lower up left. I was going to say lower upper, but that's left upper quadrant. Dull left upper quadrant abdominal pain, kind of generalized. Pain started about 2 weeks ago. She just kind of describes, I was sitting on an airplane trying to get comfortable and started having this pain, and it really hasn't gone away since. And she sort of felt off and tired since then. The pain has persisted. Now she has this abdominal fullness with the discomfort, with some early satiety, which is causing some decrease in appetite. She's also now realizing that she's lost quite a bit of weight over these past several weeks. She's not having any fevers or night sweats. She's still able to work, generally doing life, but low energy levels. Physical exam, she has some generalized abdominal pain, pushing on her belly. It's a little bit firm and distended, but not anything crazy. No palpable spleen, no palpable lymphadenopathy when you kind of go over her neck, axillas, inguinal folds. She gets worked up by her PCP, who does the following, gets a CT, abdomen pelvis. She's a 64-year-old woman with like a distended kind of firm belly that's had about 8 weeks of abdominal pain and this 20-pound weight loss. And there looks to be some sort of weird mesenteric mass. So she gets a resection of a lot of this mass and a biopsy. And the path actually shows evidence of abscess and infection, but actually no malignancy. So she gets a bunch of antibiotics. She's status post an XLAP, which is really not cool. And then, but no lymphoma diagnosis. Oh, and also just to point out, some of the lymph nodes were also excised around that mass. Her abdominal pain persists, which led to a repeat CT scan, which now shows lots of extensive lymphadenopathy, actually in the retroperitoneal area. So at this point can be assumed that if it was infectious from the mesentery, it would probably go to the retroperitoneal space. So we're like, what's happening here? So then we get a repeat biopsy of some of the retroperitoneal lymph nodes. And in this biopsy, it looks like we probably are dealing with some lymphoma. So basic principles of diagnosis, and I like to point this out because a lot of things that we see in our like tertiary care center, they go undiagnosed for so long. And so I feel like a part of our job is to, educate the larger like medical public, like PCPs and frontline providers on how to get these things diagnosed. So a good history and physical is usually characterized by some sort of painless lymphadenopathy. So good lymph node exams on your patients, palpable masses anywhere really where they shouldn't be. Organomegaly, a good abdominal exam on all of your patients, pushing good and hard to see what hurts, if you feel anything sticking out that shouldn't. really like pain or other odd symptoms where they shouldn't be, because anywhere they might have a mass or a big swollen lymph node, you can get a mass effect of some sort, whether it's around a ureter that's causing some issues with urinating, whether it's in the elbow joint and they have elbow pain. It can really, frankly, be anywhere. Another big thing with lymphomas are the B symptoms. So your fevers, weight loss of greater than 10% within 6 months, drenching night sweats. Lab studies, mostly like things I'm thinking about are our kidneys functioning well. What are our electrolytes doing? Those things might be out of whack if we're dealing with a malignancy. LFTs are helpful because if it's in the liver, that could show something. Phos, uric acid, and LDH are also sort of functions of looking for malignancy, because as we know, we're thinking about TLS from Glenn Peterson's fantastic talk. So making sure all of these things are within normal limits is a good part of your workup. I underline LDH there because it comes back into play when we're thinking about our IPI score. So keep that in the back of your head. We'll get there. And then we always get a CBC with differential. Please don't hang your hat on this, especially for initial diagnosis. Frankly, a lot of times this is normal. So this is really not meant to rule out lymphoma, but you should probably get it. Tissue biopsy is required for diagnosis, and then you need some sort of imaging at some point. Rounding out the workup, anything that can cause like big masses or giant like diffuse lymphadenopathy type pictures, are lots of infectious diseases. So these are ones that you want to make sure you kind of have covered. HIV, hepatitis, HTLV is a retrovirus that can be seen in T-cell lymphomas. CMV, EBV. You're also going to want to screen for all of your like plasma cell malignancies that Kelly just went over, because that can cause some lymphadenopathy. So getting your immunoglobulins, your SPEP, immunofixation. Autoimmune workups are often a good idea depending on like what your patient looks like. Once you have a better idea if it's B-cell lymphoma, these 4 listed here are kind of more necessary when you do think it's a B-cell lymphoma, because they help us with prognostication and choosing the therapy. So an echo to see what their heart function is. A beta-2 microglobulin is a protein that can be high in the blood with a high burden of disease. So that's something that we use as a tumor marker in lymphoma. So if it is high, it's a little bit more of a poorer prognosis. If it's normal, a better prognosis. Vitamin D level, or usually have a pretty low vitamin D level, so important to replete those. And a pregnancy test is just because you'll most likely be starting some cytotoxic chemotherapy on this patient. So our tissue biopsy, required for diagnosis. We won't even take them to our service until we have that. So it's important. Excisional biopsy is always preferred. I have to always stress that. Here's why. A lymph node to us is just this squishy thing that you can feel in their neck when you have strep throat. But it's more than just a squishy little ball. It's actually a quite intricate little organ with lots of interesting architecture. And as you saw in the picture earlier, like looking at how the B cell moves through these parts of the lymph node is actually very, very intricate. So an excisional biopsy to get the whole lymph node to look at the architecture can be super helpful in diagnosing these diseases. Core needle biopsy is appropriate if an excisional is not safe. So definitely that's the truth. Weigh your risk benefits of an excisional biopsy. Fine needle aspirate is never adequate. So even in the community, don't waste your time with that. It's kind of just a waste of time and resources. What test should we send this tissue biopsy for? We're going to send it for pathology. So the pathologist is like looking from like, bird's eye view under a microscope, but when you're talking about cells and DNA, it's a bird's eye view. And they're looking for like the monoclonal population. And what does it look like? What is the overall like architecture of the lymph node? Where is this monoclonal population located? And what do those cells look like? Immunophenotyping or flow cytometry is running these cells through a test that will tell us what proteins are on the outside of the cell. And that helps us decide where the cell of origin is coming from. And then FISH or cytogenetics is actually looking at the chromosomes in the cell and what abnormalities are going on in these cells. So you can see I kind of did it from bird's eye view to the cell surface proteins to inside the cell to looking at the cytogenetics. Again, similar picture to before, differentiating various types of lymphoma. This is kind of just showing that as they move through differentiation, the different these like BCL6 listed here is a like an oncogene, if you will, so like a gene abnormality that's characterized by cells that are within that germinal center. So what this is kind of showing is that like at every place in the differentiation, you can find a different combination of cell surface proteins and cytogenetic markers. And so that's why that's so important for diagnosis. So our patient case, I forgot an important point why I chose this case, because you saw that a lot of the first biopsies were negative for lymphoma. And I just like to point that out because a lot of our biopsies are don't give us the answers right at first. Our body is not only has cancer, but reacting to the cancer. So a lot of times our immune system or our lymph nodes are just showing inflammatory tissue or infections, like in this woman. A negative biopsy isn't always exactly right. You might have to consider rebiopsying because a lot of these can be kind of tricky and just show inflammatory tissue as like our immune system's response to this patient's lymphoma. So I forgot that, but I just wanted to point that out. So finally, we did a CT guided core needle biopsy of some of these retroperitoneal lymph nodes that were seen on the CT. And we did get a diagnosis of diffuse large B-cell lymphoma, germinal center subtype. These become really aggressive. These can become really aggressive because in the germinal center, physiologically, what's supposed to happen is these cells are meant to be replicating really fast. So if we like stop them at that place in differentiation and make them into cancer, they replicate fast. So that's a big reason why these become quite aggressive. We threw the cells through a FISH panel, so looking for the different gene abnormalities that might characterize this cell, and they were positive for a BCL2 rearrangement only. But not rearrangements in some other oncogenes called MYC and BCL6. We will get to what those are later. Here's our PET scan. So you can see, there we go, that one, right there. So we see lots of really FDG avid things in her abdomen. Hard to tell here, but that is a lot of retroperitoneal stuff. If I had the sideways version, you could see that. I don't know how many people look at PET scans every day. This is basically a radio tracer attached to a sugar molecule. And so all really metabolically active cells are going to take up more of the radio tracer and light up brighter. So the liver is kind of our baseline for physiologic metabolic activity. So that SUV is what we call it, which is a measure of brightness, is somewhere between 2 and 5, depending on male, female. So you can see that the SUVs of some of these lesions are almost 40. So these ones along the diaphragm are 40. SUVs of ones in the central abdomen, 38.9. So these are quite bright, brighter than they should be. And then the other important part of this lady is that we will come to learn that that actually has a big prognostic effect, that now we're above and below the diaphragm. So yeah, I thought, what, that's all? But yeah, it's very bright and makes things a little different here. So let's start to stage this lymphoma. So staging in lymphoma is largely based on location or extent of disease. Stage 1 being a single lymph node region. Stage 2 being 2 or more lymph node regions, but on the same side of the diaphragm. And then we get to stage 3, which is 2 or more lymph node regions, but they have to be on different sides of the diaphragm. And stage 4 is like diffuse lymphadenopathy kind of everywhere, and or just very disseminated involvement of a single organ system or area. After you determine the stage based on your imaging, then you'll get these qualifiers that you need to assign to the patient. So a qualifier of A would be that she has no B symptoms, versus B, she does have B symptoms. E means that she has extra nodal extension of disease. And actually, I had to look back at hers to make sure I was telling you right. Everything listed in the PET scan is all lymph nodes. There actually isn't like a separate mass at this point. After that, the mesenteric abscess was removed and treated. So she actually does have all lymph node involvement. And then bulky disease, any mass over 10 centimeters is considered bulky disease, and all none of hers were considered bulky. So for her, we have stage 3 because of that little guy up in her chest that I showed you. And then, of course, the abdominal findings. And then she did have 20 pounds of weight loss. So she's stage 3B disease. Diagnosis and choosing a therapy. This took me an incredible amount of literature review, and there's still no real answer. I spent lots of hours on our tumor board because that seemed like one of the best ways is to hear 4 of the leaders in lymphoma treatment on like this side of the Mississippi discuss how to treat people. So yeah, I don't know what they're doing over there. So that's, you'll see that I don't have a lot of references on the individual slides because a lot of this stuff came from just a giant like mass of like literature reading and talking to specialists in the field. So she has a diagnosis of diffuse large B-cell lymphoma, stage 3B. Spoiler alert, but we now have 3 options for that. So R-CHOP versus Pola-R-CHP versus dose-adjusted R-EPOCH. So we'll get to why we choose those different ones. GCB subtype, that's the germinal center B-cell subtype, the most common one. We consider that standard risk. FISH positive for BCL2 rearrangement, but not positive for MYC or BCL6. So it's actually a non-double hit, non-triple hit lymphoma. So again, that's another standard risk thing in her case. And then our IPI score, her IPI score is actually 3. Where does that put us in risk? And how does that change our discussion of what we're going to treat her for? And what is the IPI score? I don't know where we are in our education around here, but we will get to all of that. So the first, now what people are doing are looking back at data of first-line therapies and saying, which of these factors indicates that the patient is going to have horrible outcomes on our standard of line therapy. So what they found is that GCB versus ABC subtypes is a kind of a very big like prognostic indicator. Although don't hang your hat on this because ABC subtype is really hard to diagnose actually. You need like intensive like molecular studies that we actually don't do at our center. And so it's a thing that's talked about in the literature, but there's no real consensus as to what to do about it because people aren't even sure that we should be diagnosing it. It's very odd. Double hit, triple hit lymphoma, very poor prognosis as compared to non-double hit, triple hit lymphoma in regards to using standard of care therapy. IPI score greater than or equal to 2. Another category of patients that recently has been decided does not do well with standard of care therapy as well as we'd like them to do, and they may do better with this other regimen called Pola-R-CHP. So let's kind of go backwards a little bit to in case I have things to add, I'll go to my little notes, but I don't think I do. So standard of care therapy, R-CHOP, standard of care for 20 years. So since 2000, turn of the century, when we use that. So it's usually like 18th to 19th century. That's like our great grandparents. But we're going to be there soon. So around 2000, rituximab was added to this regimen of a bunch of chemotherapy. So that's been our standard for about 20 years now. It cures a lot of patients, don't get me wrong. It's one of the better parts of our clinic. We don't lose all these patients, but which ones does it cure? Because it's quite different when you break the patients down into categories. So in the GCB subtype that are like the 5-year overall survival is close to 80%. ABC subtype, which I already told you is a little funny, the overall survival is half of that, so 45 to 56%. And the 5-year overall survival for double hit and triple hit lymphomas in regards to standard of care R-CHOP is 22 to 27%. It's only 1 in 4 people will still be alive 5 years later. So these numbers aren't really good enough for scientists or regular people, but huge efforts are being put forth to better these regimens. So there's tons and tons of studies out there trying to figure out if anybody does better with different chemotherapies. So here's our current NCCN guideline. And the choice of therapy is at first really related to what stage we're in. So you can see this top area, stage 1 and 2, as long as it's not extensive mesenteric disease, gets RCHOP for 3 to 6 cycles, plus or minus some in-site radiation therapy is what that ISRT stands for. The next thing listed is that then stage 2 with the extensive mesenteric disease, or stage 3 or 4. Oh, wait, there's too much to get into a cute little graph like this. So you're like, oh boy. So here we are. So now we know there's more to it than stage. So you can see in that first column, stage 1 or 2, outside of mesenteric disease, is the RCHOP, like we talked about, standard of care. So what else should we be thinking about when we're choosing therapies? I listed below, ignore the red thing for right now, but so thinking about functional status, right? Like age, frailness, that kind of thing, comorbidities, heart failure, neuropathies, and yeah, especially the cardiac. I put HF there as heart failure. So that should kind of help us figure out what we're using to treat only from a side effect profile. IPI score, you'll see listed in our preferred regimens for stage 2, 3 and 4, 2 with the mesenteric disease, and 3 and 4. So where your red is now, you'll see that the second thing listed is POLA-R-CHP, specifically with an IPI score of greater than or equal to 2. So now suddenly IPI score is helping us choose therapy. And then FISH cytogenetics of disease has not made it explicitly onto the guidelines because it's so controversial and there's no real answer. But we all know it makes a huge difference. And it's always a discussion of what to use in those patients. So you'll see other recommended regimens down here are dose-adjusted REPOC. So let's get into the details of some of these factors. So you probably, if you knew previously about IPI score, it's historically used to determine our CNS prophylaxis. And only in the last 9 months has it really come into play with choosing first-line therapy. And so our IPI score includes age over 60, serum LDH greater than normal. So this is that LDH I underlined earlier. Performance status, a more poor performer status, stage 3 or 4 disease, or an extranodal involvement. So our current patient, she was 64. She had, she had a high LDH, didn't she? Yeah, she did. And then stage 3 disease. So she had 3 of these points. So that's really important here because now we have this new polaric study that telling us about this POLA-R-CHP regimen versus RCHOP. So that's kind of the IPI score piece of this, and don't worry, I'll try and put this all together as we move along. So our FISH cytogenetics. So these are like actual gene rearrangements in the malignant cells. What role do these play in prognostics in choosing our first-line therapy? So basically, we have these 3 oncogenes that we've picked out that sort of characterize higher grade lymphomas that aren't doing as well with our standard of care RCHOP. And those oncogenes are called MYC, BCL2, and BCL6. If you had 2 out of these 3, you are shown to have quite a poor prognosis with standard of care therapy. So I don't know, 5, maybe 6 years ago, the WHO does now call these subtypes of DLBCL actually high-grade B-cell lymphomas. So APPs, RNs, if you are seeing that in the notes, that is actually what it's called. We don't really call them DLBCLs anymore. We call them a high-grade B-cell lymphoma if they are a DLBCL that is a triple hit or a double hit lymphoma, hit being one of these oncogenes. They can have 1 of these, but not 2 or 3 to hit this category. Tons and tons and tons of studies show improved progression-free survival with more intensified regimens in high-grade B-cell lymphoma. But we don't know which intensified regimens have the risk benefit, right? So which ones have as few of have a good balance of working better and not so many toxicities is always what we're balancing. So again, there's been no consensus with establishing an optimal regimen here. Dose-adjusted R-EPOC is the light favorite, I think, has shown improved CR rates over R-CHOP and has less toxicities than the other intensified regimens that have been studied. That is our preferred induction regimen at UCH for high-grade B-cell lymphomas. So this is why I decided to focus in on this, because now we have these 3 choices in our just like kind of standard like bread and butter DLBCLs. And so we're talking, okay, we have R-CHOP, standard of care for DLBCL. They have to have less than or equal to 1 of those concerning oncogenes, MYC, BCL2, or BCL6, and an IPI score now less than 2. That's the piece that's new. Pola-R-CHP should now be considered in DLBCL with less than or equal to 1 concerning oncogene, and those that have an IPI score of greater than or equal to 2. We'll get to this, but Pola has a pretty good side effect. By good, I mean significant side effect of neuropathy, which is why I say we kind of have to take that pre-existing neuropathy into consideration when we're choosing this regimen. And then we have dose-adjusted R-EPOC, should be considered in lots of, I love how no one like put their money on anything. Everything should just be considered. And a few specific things. So Dr. Major wrote a paper. I came up and asked him, where do you like to use this regimen? He's like, oh, read my paper I wrote. And it was literally like the paper was exactly what I was asking. It was great. So it has been shown to have some benefit in high-grade B-cell lymphoma, as we talked about, and then in HIV-associated primary mediastinal B-cell lymphoma, and then a gray zone lymphoma is where EPOC should be considered. I just like to compare these 2 regimens because it's important to understand how many more resources dose-adjusted R-EPOC utilizes without a lot of data behind its benefits. So the big difference in chemotherapy itself is that you add in the E, which is etoposide. Other than that, they have pretty much the same regimen of chemotherapy drugs with some oral high-dose prednisone for 5 days. But you'll see dose-adjusted R-EPOC is continuous infusion in the inpatient setting, and it generally takes about 5 days to get the full infusion plus the cyclophosphamide and the rituximab. And so they're inpatient for about 5 days every 21 days. They always need growth factor, and they always need 10 days of prophylactic Levaquin and fluconazole. The main idea behind this particular regimen was interesting to me because it's very similar drug-wise, but what they decided was that maybe if we're hitting these B cells in different phases of their maturation, might we kill them better? So that's why this is given such a slow way. It's given for the 72 hours straight, so that you're really hitting it through all phases of metabolism and stuff like that, and not just in one quick pushes like an R-CHOP. So that was the biggest reasoning behind this intensified therapy. This one also allows you to dose adjust depending on their side effects. This one needs an interim PET just prior to cycle 2. And there's 6 cycles in this one, plus or minus CNS prophylaxis. R-CHOP, again, similar meds. It's all outpatient. 1 day of chemotherapy in our BIC every 21 days. We actually most often do not use growth factor in this regimen. The certain circumstances here are age over 60, some comorbidities, if they develop neutropenic fever, mucositis, that kind of thing. I would say most often we don't use Levaquin prophylaxis 4G. That would be the exception. This one also needs an interim PET scan prior to cycle 3, and R-CHOP, depending on the stage, gets 4 to 6 cycles plus or minus CNS prophy. So here's Pola-R-CHP and how it compares to our other 2 therapies. So you'll see in this regimen, the biggest thing, there's no etoposide like in R-EPOC. We've switched out the vincristine for the polatuzumab, but everything else is the same. It's given in 1 day outpatient. So it's an outpatient regimen every 21 days. We do use growth factor for this particular regimen. It is thought to be a little bit more immunosuppressive with the Pola versus the vincristine. The fluke Levaquin prophylaxis is only in the certain circumstances, mostly the ones I've already named. The polatuzumab has the most similar mechanism of action with vincristine. In general, it's this is all real fancy terms, but generally it's a microtubule inhibitor. And right, if you don't have like the structure for your cell, the microtubules, then that cell falls apart and dies. And so the microtubule inhibitors are also the ones that generally across the board are going to cause more neuropathy. And so that's kind of why you'll see in the next note on there, pola and vincristine would never really be given together because that cumulative effect of like neurotoxicity as a peripheral neuropathy would be much too high. So the pola is in place of the vincristine. Yeah, so a little bit more similar to R-CHOP, except it does have the growth factor need. So here's our patient case. So she has a diffuse large B-cell lymphoma, stage 3B. We have these 3 options of therapy: R-CHOP, pola, R-CHIP, dose-adjusted R-EPOCH. No one would say you were wrong if you chose any of these 3, just so you know. GCB subtype, standard risk, we talked about. Only one of these rearrangements, standard risk. What her increase from maybe her increased risk of relapse with standard is her risk is that IPI score, age, stage, and LDH. She has an increased risk of relapse with standard of care therapy. So she got pola R-CHIP times 2 cycles, followed by an interim PET. We do that just prior to cycle 3, so we can make sure 2 cycles gets all of its going. Interim PET shows huge decrease in all FDG avid sites. There is still a little bit of remaining uptake, but it's that or less than the liver. And there's no new areas of disease. So we have a pretty good response to this stuff. So she was then proceeded with 4 more cycles of pola R-CHIP, so treated with a total of 6 cycles of pola R-CHIP. With a complete metabolic response on our end of treatment PET. So that's cool. So she's going to go to surveillance. We get the end of treatment PET about 6 weeks after the completion of therapy. And so then she went to surveillance, which is every 3 months labs and assessment. This is not just a poo-poo surveillance. These patients are still at high risk of relapsing. So every time they're seen, we have to be doing a really good history and physical exam, that of which I described at diagnosis, as well as the lab things that I have shown you. This varies, so don't write this down. Her particular plan is that her next imaging is at the 12-month mark post completion of therapy. Some people would get it maybe 6 months. So that depends on the physician. It depends on the aggressiveness of the cancer, that kind of thing. She is currently 10 months post completion of therapy without any evidence of relapse. This guy's cute. So a colleague just like last week told me I should have a picture every couple of slides, and I didn't have one. So here he is. And I thought it was good because the relapse refractory setting in DLBCL and high-grade B-cell lymphoma and follicular too is wild. The amount of studies and research happening is just amazing, and it's exciting, as Kelly put it, but also very hard to talk about. So here we go. This part of the NCC guideline hasn't changed. So you're still going to see the role of transplant in these relapse refractory B-cell lymphomas. So some salvage chemotherapy bridging to an auto or allo transplant. This is in the setting of relapse after 12 months. So post 12 months after their end of treatment. Then we have all this stuff where we're like, our T cells should be doing the job here. Why aren't they? Let's help them. Let's help these cells that we actually already are born with. So this is supposed to be showing the virus. There is not what I'm talking about. The virus is in our intents purposes for this talk is the cancer. So a cancer infected cell, our T cells really should be fighting this, but they're not. So CAR T cell therapy and BiTEs or bispecific T cell engagers are meant to re-engage or re-recruit our own T cells to kill these cancers. So you can see kind of how the T cell works. You have to get at least one T cell. I think it just takes one. Heather can correct me, but to attack this bad cell, and then it releases all these cytokines to get its whole militia going to fight this thing. So we just got to recruit a couple. And so we've found ways to do that with drugs. Well, CAR T is not really a drug, but you know. Okay. Another one we're looking at is tafasitamab, which is used in combination with lenalidomide. This is a monoclonal antibody. And then loncastuximab is a antibody drug conjugate. Both of these target CD19, but other options in the relapse refractory setting. This is just a little picture of CAR T-cell therapy. We take the T-cell out of the person. We put on a new receptor so that it knows how to find the cancer. And then we put those fancy new T-cells back into the patient so that they can go find that cancer and kill it. So here's a fancier picture where this is our kind of lame T-cell down here that doesn't seem to recognize that surface protein on the tumor cell. But this is our fancy CAR T-cell up here that has this new antigen receptor that is going to attack the surface protein on this tumor cell. So that's how CAR T-cell works. And then, well, yeah. So, you know, you've heard a lot about CAR T-cell today. I think my only goal here is to tell you that it's, thank goodness for the last year and a half or so, approved in the second line setting. So we had this big problem probably 2 years ago where a lot of the CAR T-cell patients might just die of their disease waiting on CAR T, or just be too sick to even go through it because it wasn't approved until like third or fourth line. So it's now approved second line, which means a lot healthier patients are getting this therapy, and it really can do quite well. These are the four, they're all targeted to CD19, which is on most B cells. And they all have slightly different FDA approvals. But yeah, these are the four that we're utilizing in lymphoma therapy with pretty awesome outcomes. Bispecific T-cell engagers are like all the rage this summer. Mosunetuzumab approved for follicular lymphoma, so more indolent lymphoma. Epcoritamab and glofitamab for more of your aggressive D-cell BCLs or high-grade B-cell lymphomas. Kelly already explained this to you very beautifully, but yeah, our drug is that linker guy. And so it has one side of it that holds hands with the CD3 cell on the T cell, and it has one side that holds hands with the tumor cell on the CD20 side. So it brings them close together to destroy them, with like any good relationship, I guess. So again, this is just a way for us to redirect or engage or recruit these T cells that they know how to kill this cancer. They just need a little boost to tell them which ones to do it to. So if we can get a couple of these T cells to bind, then they can release these pro-inflammatory cytokines that tell everyone else to come attack these guys. This slide is boring on purpose to make a point, because Mosun and Epcor, well, Mosun's like a little different because has a different indication. It's more for the follicular side of things. Epcoritamab and glofitamab like are kind of similar, and like all have different endpoints, so they're really hard to compare in the studies. And so I think the biggest point here is like, how do we choose between them at this point? We don't really know. Like the data is just kind of like dizzying. So here's what people in our center are kind of looking at and utilizing to kind of help determine. I was realizing during Glenn's talk that I didn't have all this memorized because I've heard his talk before. I was trying to memorize it and said, this is silly. I'm just going to write it down and I can have access to it. So anyways, the Mosun is IV. For more follicular, it's the duration of therapy is nice because if there's a CR, you can stop at 8 cycles. If there's just a partial response, you can go up to 17 cycles. It's 21-day length, and the admission, you don't have to admit for this one, which is kind of nice, only if it's clinically warranted. So up to us. Epcoritamab is sub-Q. We're like, oh, is that cool for like chair time in our infusion center? But then Epco is given, quite a bit more frequently in the first couple cycles. So like, even though it's sub-Q, it's given more frequently in the first 3 to 4 cycles. So like, is that better for like logistical chair time and stuff like that? The the end game is that it's 28-day cycles. And once we get out to cycles 4 through 9 are only every other week, but then after cycle 10 is just day 1. So it's like a lot at the beginning. It does pretty much highly recommend 1 admission, which is once you get to that top dose, you admit for CRS. You admit for CRS watch. And this one goes indefinitely until progression of disease or unacceptable toxicities. Very sorry. We don't mind acceptable toxicities. So that's kind of the things we talk about with epcoritamab, I think. Yeah. And then compare that to Glofi, which this Glofi is a little bit more unique. It requires 1 dose of obinutuzumab, which is a CD20 monoclonal antibody to kind of like get rid of some bulky disease before you give the drug. And so it requires day 1 is a pre-treat with Obin, and then you admit on day 8 for the first kind of step up dose of Glofi. And you basically keep admitting for each dose if the CRS if you had CRS over grade 2 for the previous doses. So yeah, there's a little bit, few more admissions with that one. It's every 21 days, it's IV. So, I mean, we're looking at cycle lengths, admission required, IV versus sub-Q, fixed duration versus indefinite. So these are just things that I've heard us discuss, and we're trying to choose between these options. I probably should have mentioned that because all the T-cell, this is a T-cell engagement type of process, just like CAR T, our side effects are quite similar. So in case I forgot to mention that, there's still big side effects are CRS, cytokine release syndrome, and tumor lysis. That's not right. Neurotoxicity. Thank you. Last other options, which are good options, but unfortunately I don't have a lot of new data with these because honestly, these came out about 2 years ago. And in that time, CAR T cell therapy was approved for 2nd-line therapy. And then all the bites started coming out. So we had a handful of patients on these drugs, and then they've kind of, we haven't really had a place to use them very frequently, but they shouldn't go unnoticed because they're in a lot of clinical trials in combination with other drugs. And I was just talking with a rep who has new 2-year data coming out on these. So there's definitely a place in therapy for these guys. I think the data collection has slowed down a little bit because of the bites in CAR T cell. But tafasitamab is a monoclonal antibody versus CD19. So it's going to bind to all the cells that have CD19 on the outside and then mediate a cell lysis. And then it was studied and now used in combination with lenalidomide or Revlimid. So this one is a 28-day cycle. They do Revlimid days 1 through 21 of a 28-day cycle, and then they get Tafa IV infusions and kind of a stepped down approach pretty frequently, and then less and less as you go. The next one is also targeting CD19. It's called loncastuximab. This is an antibody drug conjugate, so a little bit different, where a monoclonal antibody is actually mediating cell apoptosis, so helping it kill itself. A antibody drug conjugate is linking on to anything with CD19 and then inserting a little toxic medication into the cell to get rid of the cell. So it attaches on and delivers a alkylating agent, which is akin to all of your old school heavy chemotherapies, cyclophosphamide, bendamustine, cisplatin, melphalan, stuff like that. So that's kind of how that one works. That one, let's see, I'm trying to see that one's in 21-day cycles. And it kind of starts with higher doses, and then actually the dose cuts in half for the maintenance of it. So these are kind of our last 2 options. More to come on these. Again, the data and the research behind these have kind of slowed down because other things sort of got in the way and distracted us, but we'll need them. These people, unfortunately, are still going to relapse after bites and CAR Ts, but maybe not. We'll see. Yeah. Anyone have questions? Anything? Take care.
For the epcoritamab, or however I have trouble pronouncing that too, do you think we're using that? I know particularly of one patient that I see all the time, and I'm doing spinal taps on her, and yeah. And she ends up in the hospital after each and every single dose. She's older, frail. Is that patient population that we're targeting with that?
Yeah, I mean,
therapy?
these are really said to be well tolerated drugs outside of the first cycle.
Mhm.
For us to still be calling her fevers and stuff
Mhm.
related to CRS is weird. I think it's just been a diagnosis of exclusion at this point, because the literature is saying, like, after those step up doses after cycle 1, there's like pretty nil risk of the continued CRS and neurotox. So she's a really interesting one, and she's like our patient one and only thus far with that drug. And so I kind of wonder if that's going to impact how our physicians use Glofi versus Epco, because yeah, we keep calling her CRS and she's now into cycle 3, which is not really written about.
Yeah. Yeah.